Thank you very much, and good afternoon, everyone. I hope you had a wonderful forum. I can't wait for the time when we'll be together in person. I'm going to close the meeting with my remarks on moral determinants of health, and I want to give you a little bit of framing of that. I'm going to be describing a rather personal journey over the past few years, growing concerns on my part, and then a call for some real change. I'll warn you that this doesn't end with a neat bow. I'm really going to raise more questions than I answer, but I'd love you to be considering them. I also should warn you that this is very much from a U.S. perspective. It's the country I obviously know best, but I'm going to guess that some of the issues that I want to raise apply to many other countries around the world, including yours. It'll be for you to judge. Back in the early days of my careers, I began to study the scientific foundations for improvement of complex systems, including healthcare. One rule came to the fore, which has remained steady in my mind ever since, which is this: you'll never improve without aims. So all improvement begins with aim. I will never learn to speak Spanish unless I decide to speak Spanish. Healthcare will never improve unless it decides to improve, and it has to decide what to improve. And so a turning point in that kind of thinking came in the year 1999, and then again in 2001, from the Institute of Medicine, now the National Academy of Medicine in the United States, where these two reports, which you may already know well, appeared: Two Errors Human and Crossing the Quality Chasm. I served on the committee that wrote these reports and had a hand in shaping what I'm sharing with you. Two Errors Human was a report on errors and injuries in healthcare, showing how much harm is done by the care that is intended to help people, because we've not designed healthcare for safety. That report famously estimated in the United States that 44,000 to 98,000 deaths per year occur in hospitals due to errors in care. Shortly after, Sir Liam Donaldson oversaw the report in the UK called An Organization with a Memory, which came up with similar findings in safety in the UK. 2 years later, the National Academy of Medicine, the Institute of Medicine, published a more comprehensive report called Crossing the Quality Chasm that laid out 6 aims for improvement: safety, not injuring people, in care; effectiveness, promising science-based care, evidence-based care to everyone; patient-centeredness, a shift of power to patients and families and communities, focusing on what matters to them, as Maureen Bisignano is today teaching us; timeliness, reduction of delay, which was essentially the most important aim in the UK at the time I first became involved in that issue; efficiency, reduction of waste; and equity, closing racial and socioeconomic gaps. These aims for improvement were adopted very widely and became the focus of energies for many health systems in the United States and abroad. A few years later, my colleagues Tom Nolan and John Whittington, faculty members at the Institute for Healthcare Improvement, improved that framing of aims by pointing out that the 6 Institute of Medicine aims, the National Academy aims, safe, effective, patient-centered, timely, efficient, equitable care, refers largely to the experience of care for people who are in care. But they know, as we know, that the causes of illness, injury, and disability do not lie in healthcare. They lie outside healthcare, in our genetic endowments, but also importantly in the conditions in which we grow up, live, work, play, the social determinants of health. And they said, if we're really going to focus on well-being, we need a second set of goals in addition to the Institute of Medicine goals, and that was to improve the health of populations, improve the health of individuals, and improve the health of populations. And do all of that without waste, reducing per capita costs so that the resources that are put into healthcare can be used wisely and not excessively, and so that other important social endeavors can be engaged in. Better care for individuals, better health for populations, lower per capita cost. If you had stopped me a few years ago and said, what are you working on, Don? What's your mission? It would have been the triple aim. And many nations, not just organizations, have adopted the triple aim as their focus. We have a new context for all of this, of course, and that is the COVID pandemic, which has changed the game largely, although probably not the aims. COVID era has brought us a whole set of choices as leaders of healthcare about the way we approach those aims. COVID has taught us to move fast. We're now moving more quickly in our healthcare world than I've ever seen before. Journals are publishing articles relevant to the pandemic in days. which used to take months to be reviewed. The National Academy of Medicine has a committee to advise government and private sector on COVID. That committee produces reports in weeks, which used to take months or even years to produce. We have clinicians all over the world exchanging knowledge faster than I've ever seen before. The famous Nightingale hospitals in the UK set up in weeks, converting large convention centers to intensive care settings. Luckily not needed, but ready for use if needed. We can keep that speed or lose it. We can go back to the slower pace if we wish when COVID's over, but we ought to think about that. Standardization is another change. COVID has made us avid for evidence-based medical guidance. Clinicians all over the world are in touch with each other, searching the literature, searching the world for the best way to prone patients on ventilators, to use remdesivir, to use dexamethasone, the best ways to approach vaccination. We become avid for science-based care. We can keep that after the pandemic or toss it. We've, of course, moved largely to virtual care. There are organizations in my country that went from 5% virtual visits to 95% virtual visits in a matter of weeks. That's a change we've been talking about for decades, and suddenly it happened. And we're going to get some choices in the future as to how much care we want to be giving outside the walls of our institutions. COVID raised questions about protection of the workforce. We got caught on our heels here. We did not protect the workforce, not in my country. And we have broadened our view of what the workforce is. We now understand it to include far many more people in job roles than ever before. In the future, we're going to have to think hard about how we protect the workforce against physical and psychological harms. Preparedness itself is a whole other topic. My country, for example, the United States, was rated by indices as very prepared for a pandemic. Turned out we were not. We really were caught again on our heels, and we're going to have a big reckoning in our country and in many others about what preparedness for 21st century threats ought to look like. And then the main topic I want to talk with you about, and that is inequity. COVID wasn't the first, by any means, reminder of inequity as a plague in the world. But we know that COVID hit communities of color and communities of disadvantage far harder than communities with more wealth, and that's playing out not just within countries but globally. And that's what I want to explore with you in the remainder of my time. I want to take a little detour, though, about that workforce issue. We're going to be talking about inequity, but I will show you that in the United States, my country, inequity isn't just out there in the communities that the workforce serves. It's right here in healthcare. And we have some work to do to restore justice and equity within the healthcare system in the United States. Because of our healthcare insurance system, more than 800,000 healthcare workers and almost 1.1 million of their children live in poverty across the United States. That is, they're paid below the poverty level. And of the 18.5 million people who are employed in the healthcare industry, nearly 10% of them, 1.7 million, earn so little that they have to get care through a government welfare program, Medicaid. And believe it or not, in the United States, 1.4 million healthcare workers have no health insurance at all. I don't think that would be true in most of the other countries listening to my voice today. But I do believe that there is a call now for some insight, some scrutiny, self-scrutiny about whether justice exists within the healthcare workforce itself. Now, I'm going to be talking about inequity, but I'm going to be talking about it with the help of a hero of mine, Sir Michael Marmot, as you know, a distinguished leader in epidemiology in the world over the past 4 decades. Sir Michael has done a great service in his 2015 book called The Health Gap. In this book, Sir Michael pulled together the literature on what we refer to now as social determinants of health. That is, those factors that affect our illness, injury, and disability rates, and that explain many of the variations in health that we see across countries and within countries, among countries and within countries. The Health Gap is a stunning book. I strongly recommend it to you because what Michael has done is pulled together decades of research literature and made it highly accessible in a highly orderly form that allows us, if we want, to carry on conversations and guide actions toward not just the healthcare repair shop, to use the language of that Lord Nigel Crisp has provided in his recent book, that the hospital is a repair shop. Health is not made in the hospital, it's made at home. It's made in communities. It's made by the factors that Sir Michael examines. Improving population health is going to require mastery of the science and knowledge we have about what creates health. Now, in his book, Sir Michael sorts the literature into 5 categories of social determinant of health, 5 kinds of influences that determine rates of illness, injury, and disability in our populations. The first of those categories is early childhood experiences. What happens to kids in their early years has strong effects on their well-being, not just as children, but on their health as adults, their longevity, their lifespans, the prevalence of chronic illnesses and acute illnesses. And I'll show you more about that in a little while. This, of course, has been addressed very directly in Scotland with the Early Years Collaborative and now the Children and Youth Collaborative, which has as a Scottish health service realized that if its job is to produce health, it's going to need to focus on children. And so would Michael Marmot agree. The second category Marmot talks about is education. It's the availability of high quality educational opportunity across the population to everyone, especially women and girls, but it's a kind of commitment to the highest possible opportunities for education and self-development as a matter of policy, assuring education for all. The third category is work and workplace. This has to do with the level of minimum wage. Is minimum wage a stingy, small number, or is it the kind of minimum income that allows people to live whole and full lives, develop their talents, participate in societies? And is the workplace a protective place, protected both physically and psychologically, protected against safety issues in the workplace, but also supporting meaning and engagement in work? Societies that engage in strong supports to workforces are societies that live longer and are healthier. The experiences of elders is Marmot's fourth category. This is the characteristic of societies that commit to supports to older people, keeping them engaged in society, engaged in the economy if they wish and can, engaged in avoiding isolation. Countries that invest in elder supports live longer and are healthier. And finally, community resilience. This is a potpourri, a collection of characteristics, which probably would be to my mind first if you said social determinants of health, conditions in communities that support health and well-being, food security, housing security, recreational opportunities, clean air and water, a fair criminal justice system, a restorative justice system, control of violence, and the characteristics that make communities livable and cohesive. Countries that have good experiences for early childhood, strong and equitable education systems, strong protections at the workplace, supports for elders, especially against loneliness, and a list of community resources, these societies live longer, a lot longer. Even among Western democracies, the differences in life expectancy between countries that invest in these characteristics and those that invest less can be as long as 8 or 10 years. My country, the United States, does not score well on these social determinants of health, I must tell you. Not only are we not the longest lived country in the world, we rank 30th or 40th, but case by case, determinant by determinant, we don't score well. Our conditions of our children are not anywhere near the best among OECD countries. Our educational system at its best is superb, but many of our people don't have access to the best education. Our minimum wage structure is not generous compared to other Western democracies. We don't have a strong elder care policy in our country, and our infrastructures in communities like food security, housing security, transportation, and so on are by no means the best in the world. And as a result, we don't have the best health in the world. And despite the fact that we put much more than any other country into our repair shop, more than almost double the rate of investment in health care as the other country. Health care does not generate health. Marmot asked the question, why? Why do countries differ in these 5 determinants of health? And that leads into his 6th topic in his book, which he calls fairness. It's a big idea in Marmot's world. It's a sense of community, solidarity, duty to each other, a sense of compassion and support to people who are at disadvantage. And what he notes is that communities and countries that invest in fairness, solidarity, and equity are longer-lived communities. This is the causal chain that Marmot talks about. Inequities in power, money, and resources, fairness, give rise to inequities in the conditions of daily life, social determinants of health, which in turn lead to inequities in health. This is a causal chain that Sir Michael talks about based on the science. The consequences of underinvestment in social determinants are very big. This is a slide from the work of my Harvard colleague, Professor Raj Chetty, who has, in this case, shown us the relationship in the United States between household income percentile, from the lowest to the highest income on the horizontal axis, and expected age of death for people who live to age 40. For people who live to age 40, at what age are they expected to die? What you see is between the lowest 1% of the income level and the highest 1% of income level, the difference in life expectancy at age 40 is 10 years for women and 15 years for men. These social determinants, in this case related to household income and economic security, are monstrous. They're enormous compared to the effects of the repair shop. Let me show you a little more about what one of these social determinants looks like, again, in the United States. This is a report, a wonderful report from the Surgeon General of the state of California. It's available online, and it's a deep dive into the first of Marmot's social determinants, early childhood experience. This report explores the evidence and the consequences of what are known as adverse childhood experience, ACEs, or toxic stress in children on general health status. Adverse childhood experiences were first defined by researchers from the Kaiser Permanente Healthcare Organization and the Centers for Disease Control. And this publication delves deeply into the science behind adverse childhood experiences. But in that publication is this table. What's going on here is an odds ratio calculation for children who have 4 or more adverse childhood experiences. Adverse childhood experiences are stresses in early childhood, like observing violence or exposure to substance misuse or environmental threats. The score goes from 1 to 10. That's the maximum number of ACEs that can be counted. This shows that for children in early childhood who have 4 or more adverse childhood experiences, look at the rates of diseases, which are the leading causes of death in the U.S. in adulthood. Childhood exposures leading to adult diseases, double the rate of heart disease, 2.3 times the rate of cancer, 2.6 times the accident rate, 3.1 times the rate of chronic lung disease, and for mental health problems, as multiples as high as 10 or more. Adverse childhood experiences are very, very strong correlates and very likely determinants of health status in adulthood. So let's look at adverse childhood experiences. This is research from a multi-university consortium studying the Childhood Opportunity Index. This is the second version published just last year in the journal Health Affairs by that university consortium. This group of researchers measures what they call childhood opportunity in every single one of the over 70,000 census tract neighborhoods in the United States. And the index that they use is constructed by the researchers using a whole bunch of factors, including here factors in early childhood education, health environment, social and economic conditions, the conditions of early childhood. Here are 2 hypothetical neighborhoods, neighborhood A and neighborhood B. Neighborhood A, census tract A, has a much lower, very low childhood opportunity index compared to neighborhood B. And you can see in neighborhood A, there's a higher poverty rate, lower enrollment in early childhood education, less recreational opportunity and green space, less food security, less housing security. This kind of distinction between very low and very high opportunity can then be applied to census tracts all over the United States. In my country, this is where kids live. On the left, you see the distribution of children, in that case, white and Asian and Pacific Islander children, by census tract from very low opportunity to very high opportunity. I want to pause here very quickly to say that I am well aware of the literature on asset-based indicators as opposed to deficit-based indicators. And I know very well that in what would be rated a low opportunity neighborhood may be many, many strengths, cultural strengths, and other forms of supports that are not accounted for by this index. With this index studies stresses in kids. Maybe 5 to 8% of white kids living in very low opportunity neighborhoods, 40% or more, and over 60% or 70% in very high or very high opportunity neighborhoods. On the right side is where African American and Hispanic, Latinx kids live in the United States. The opposite distribution, 46% of African American children growing up in very low opportunity neighborhoods and fewer than 10% in very high opportunity neighborhoods. You can see this in a very dramatic way in this material from the researchers. Here they've taken one neighborhood in America. This is the metropolitan area around the city of Baltimore, Maryland. They could have picked any city, Chicago, New York, Boston, or San Francisco, and they would have had similar results. But what they've done here is taken the census tracts around the Baltimore, Towson, Maryland area and color-coded them. So very high opportunity census tracts are given a darker color, and very low opportunity census tracts are given a lighter color. Here is where white children live in that metropolitan area. Every single green dot, it represents 20 children, white children, aged 0 to 17 years of age, living mostly, as you can see, in relatively high opportunity areas, neighborhoods. And here's where African American kids live. Every yellow dot is representing 20 African American children aged 0 to 17 years. This is segregation, structural racism, built into the experiences of kids in these neighborhoods. This, I must tell you, sadly, is reflected in the history of the United States in laws like mortgage redlining back in the early part of this century, in which there actually was direct disadvantage for African Americans, say, in obtaining supports to buy houses. So this is what structural racism looks like in a country with that history. The result in the United States is asymmetry in health status by race. Black infant mortality in the United States more than double white. For our indigenous population, American Indians, more than double the rate of infant mortality. And of course, we've seen that in the COVID pandemic, 2 or 3 or sometimes 4 times the rate of deaths for people of color in my country compared to whites. This is the effect of social determinants playing out in health. Exactly the causal chain that Sir Michael Marmot talks about. It's true around the world. Here is what's called a subway map version showing in London, the London Tube, more or less, where every single tube stop has been indexed with the life expectancy of the people who live in that area. Here in the wealthy area around Oxford Circus in the West End in London, people living into their 90s as expected lifespan. If you cross to the more stressed and lower income areas of London and in East London, there's the Star Lane tube stop with a life expectancy in the mid 70s. The difference across that number of miles of 21 years of life expectancy from the highest to the lowest areas, totally associated with place, totally associated with the conditions of life, the social determinants in those areas. If you had a single subway line, a tube line from Oxford Circus to Star Lane, and you traveled on it, you'd be losing 2.6 years per mile traveled. I owe this literature, by the way, to my colleague Ben Collins, formerly with the King's Fund. It's true in my country. Here is indicated an area in Midtown Manhattan, a wealthy area around 96th Street, median income around $180,000 a year, and mostly white, and very few children on our social support system, Medicaid. Here is a few miles north is the stressed area of the South Bronx. The median income here is less than a third of Midtown Manhattan. Very majority populations are people of color. More than half the children born into Medicaid. And across that journey is a life expectancy difference of 10 years, 2.3 years per mile lost on the subway. Again, I thank Ben Collins for this data. In other cities in the United States, it's the same thing. From the wealthy Chicago Loop area to the West Chicago area, a couple of miles, there's a 16-year difference in life expectancy. In the Flint, Michigan, a 15-year life expectancy in a small city from wealthy to poor. Famously in Glasgow, Scotland, where the original subway map, I think, was drawn, the bus map, over a 20 or 25-year difference in life expectancy. How big is this? It's enormous. 6 months for every minute on the subway, 2.3 years for every mile traveled. But let's take a deeper dive. In the British Medical Journal Open in 2015, this review paper was published on the effects of statins. Statins are sort of like, I guess, a medical breakthrough. Maybe some would say a medical miracle. A lot of quality indicators are attached to whether people who have high cholesterol are put on statins. These researchers, Christensen and colleagues, asked the question, what does the literature say about the effects of statins on survival in randomized trials? And when they looked at the randomized trials on primary prevention for use of statins, they say death was postponed between, well, actually, -5 days and 19 days in primary prevention trials. We're looking at approximately, for the most favorable studies of primary prevention of statins, a medical breakthrough, 20 years on statins may save 20 days of lifespan. That's a breakthrough. 20 days is what you lose riding the subway in Manhattan from Midtown Manhattan to the South Bronx in 7 seconds on the subway train. Crossing Glasgow from high income to low income area, you lose 20 days and 43 feet on a Glasgow bus. These are deceptive, of course, because it's not a ramp. It's not like you steadily lose life expectancies. You travel from Midtown Manhattan to the South Bronx or across Glasgow. These are more like cliffs. You arrive in areas, localities, places where the social conditions lead to dramatic, sudden changes in life expectancy and well-being. But it's the proportion I want you to see. When we look at the generators of health, health care is a weakling. It is a tiny influence compared to the influences of the social determinants of health that Sir Michael has written about. In my country, the effects are enormous. I have this slide from Sir Michael. I thank him for it. This shows the life expectancy arriving at age 50 of men at age 50 in the United States, depending on when the men were born. These are men who were born in 1920 and would reach age 50 in 1970. At the other end are men born in 1950 who reach age 50 at the year 2000. The life expectancy of the wealthiest men in my country has grown quite steadily during that 30-year period, born in 1920 to born in 1950. Well, for the poorest, the lowest income, 10 and 20% of men, very low in life expectancy. For women, it's even worse. Women in the poorest, 10, 20, and 30%, even the middle 50%, 10, 20, and 30% of Americans have lost life expectancy over that 30-year period. Social determinants of health are massive. In my country, I must say, they're closely related to race and racism. Our 400-year history of slavery has led to structural conditions in the United States which place African Americans and other communities of color, especially Latinx and indigenous Americans, American Indians and Alaska Natives, at extraordinary disadvantage just because of the color of their skin. And so it happens that in the United States, ethnicity and race are strongly correlated with, and according to researchers like the wonderful Dr. David Williams at Harvard, determinative of social determinants of health. So where does this leave us? I warned you that I was going to end in a relatively uncomfortable place. the fact is that nothing that I've shared with you is new, nothing at all. What Sir Michael reviews in his 2015 book is research at least 20, 30 years old. In fact, you could argue it's nearly a century old in some ways. Nothing about the social determinants really is news to us today. And the effects that we saw in the COVID pandemic, which are manifestations of the power of social determinants of health, should be no surprise to anyone familiar with the epidemiological literature, even at the elementary level. But here's the perplexity. Why could it be that smart nations, wise nations, have observed and known about this discrepancy for many, many decades and not fixed it? Why in my country are we putting nearly $4 trillion a year into the repair shop and still live with the forms of deficiency in social determinants that we live with? Why would we do that? Is it good for the economy? Of course not. Well-being, longevity, vitality, and populations is an economic benefit, not just a moral one. And yet somehow, against our own interests, we continue not to invest in the social determinants. Now, in OECD countries at large, I must say the investment in social determinants is greater than in the United States. As Betsy Bradley, the researcher, proved in a famous paper, for OECD countries, there's about $2 invested in social care, social supports for every $1 in healthcare. In my country, it's quite the opposite. We have, for every $1 in healthcare, we have 90 cents in social supports. But nonetheless, I would argue that in my country, egregiously, but in other countries around the world, wealthy countries, the investment in repairing social determinants is still deficient. This is not news, of course, and in the UK, for example, the struggle has been on for decades to begin to do more about social supports and social services, the social determinants. But again, it's an uphill battle. The tendency is always to invest in the repair shop instead of in the true causes. I must say, I think that may be about to change in NHS England anyway, where the arrival of integrated care systems, place-based systems with consolidated budgets and the ability to focus on the needs of populations and hopefully fully the triple aim for populations, I think may open the door for renewed new investments, new proportionate investments in social determinants at a level we've not seen before. But that's not for sure. This will involve forms of cooperation between local authorities and local governments, many of whom have responsibility for factors related to social determinants, and the health service. So instead of being competitors for resources, they become highly cooperative. The place-based care idea that's at the core of the integrated care system, I think, is important. And we've seen it play out in Scotland. The results are not all by any means in yet, but Scotland is a country which has decided to invest in social determinants as a support function itself in concert with other elements of civil society and government. But the investments remain asymmetric, and that's the final point I want to make. I'm kind of ringing an alarm here. I want to talk about our countries, mine especially, but yours also, about what it would take for us to change this investment, to begin to focus on investing our resources, our energies in the pursuit of health and well-being, and not just healthcare. I think we require a moral calibration. I mean, I know it sounds high-minded, stiff-necked, but I think we better check on what kind of countries we wish to be, what kind of communities we wish to be. I think we need to go back to Sir Michael Marmot's sixth factor, fairness, and ask a deep question as to whether we want that, what that is in the Charter, the Constitution, the purpose of our communities. And for me, it is. If we did that, the campaign for health would look different. We campaign for investments guided by morality, the moral determinants of health. We would honor the sum and substance of the major human rights treaties of the world. My country has remained a non-signatory to important elements like the UN Convention on the Rights of Children, the rights of women, the rights of migrants and their families. But others have signed. We need to mean it. The human rights vocabulary for the pursuit of the social determinants needs to be made real. In my country, that includes unequivocally making health care a human right. We have not done that. The United States leaves 30 million people out. Happily, most other Western democracies, most other democracies have not done that. They've made healthcare a human right. We need to assure it, and that means quality healthcare. In the recent reports from the National Academy of Medicine, the Lancet Commission, and the World Health Organization, OECD, and the World Bank, we've called for a right to quality of care. We need to get serious as a world on reversal of climate change. This is the largest threat to health that our species will face through climate change disasters, climate refugees, food insecurity, water insecurity, weather events. We've only begun to see it, and we had better take this seriously, or it's going to make the pandemic look pale by comparison. I think we need radical reform of criminal justice systems. Some countries, I'll name Norway as one, have highly restorative healing approaches to justice-involved people. My country does not. We have 2.3 million people in our prisons and jails, 10 million cycling through every year. We have a system that does not offer sound alternatives to incarceration. It's highly racist. A 7-to-1 incarceration rate for Black Americans compared to whites, 5-to-1 for Latinos. I don't know the status of the criminal justice system in your country, but people who are justice involved tend to be people with behavioral health problems, substance misuse conditions, and they need to be addressed with compassion and support and restoration. We need compassionate immigration reform in a world plagued by tribalism and cruel immigration policies. I think as Western nations, we need to commit to ending hunger and homelessness. My country first. We have 40 million hungry people in our wealthy country, America, 700,000 chronically homeless, millions intermittently homeless. There's no reason for that, and that is a health issue. And we need to protect democratic institutions. Government must work with science and with dignity, focused on equity, and in many of our countries, unfortunately, that is threatened today. I put this up as a slide to a health convention because this is health. That's my point. We in the healthcare world, we committed to healing and reduction of suffering, need to become party, not just party to, but in the pursuit of changing the causes of ill health, injury, and disability. And that list includes what I'm showing you here. You may not have thought when you became a doctor or a nurse or a healthcare manager that it was your job to work on climate change or criminal justice or immigration reform or homelessness. I say it is. If these are the causes of illness, injury, and disability, and you took an oath as a healer, it's your job and mine to address these. What can healthcare systems do to help advance these aims for social and moral determinants of health? That's an active question. I hope, by the way, in the UK and in England with the integrated care systems, this is exactly the question. It's going to come to the table of the leadership groups, questions for investments and new ways to think about the workplace and work, new ways to think about the organization of the healing enterprise itself. If we are to be healers, we have to work against the causes of illness, injury, and disability, and that's far more than delivering high quality and proper health care. Thank you very much. I look forward now, perhaps, to some questions, and I look forward to ongoing dialogue.